in open angle glaucoma patient, and you said there was a change blink rate. Now I assume the blink
I
rate
think
is
so.
lower.
Yep.
You are live. Go ahead.
Yes. Okay. Why do you think is the blink rate lower? I mean, if you have ocular surface disease, you should think that you blink more because pain or whatever. Can I ask? You spoke about the proportion of patients being on
surgical
BCG.
counseling,
Perhaps one of your
such that it will help them
patients
understand
offers because
what
they
to
have
expect
endophthalmitis angle surgery glaucoma.
post-operatively.
Is that possible?
Yes, of course. That's actually the most important part of our job, really. I generally spend an hour, at least an hour, with families, and I try to have them understand the situation and their kids needs to be followed for a lifetime, and there might be a need for any further medication and any further interventions. That's the most important part,
You
I think.
reported that very interesting,
Thank
but
you.
also a little bit
The
complicated
next question
development
is to
with the
Jinglin.
steroid-induced
So there is a
glaucoma.
question asking that
And you
PCG and
said
GOAG
that
is a continuum
steroid-induced
spectrum of
glaucoma
disease,
obviously
and
is
sometimes
something
patients
that is
do
slow to start
manifest
blinking,
just
and it can
somewhere
progress to
after
quite
18 years old to early 20s. So
via
at what
so-called
age would you
hospitalization.
consider or
So
not
my
consider
question
goniotomy as your
is a
primary
twofold. The
surgical
first one,
option?
would that only refer to steroid-induced
Hi.
glaucoma? Because
So you can argue that primary congenital glaucoma, GOAG, as well as high pressure adult onset POAG as a
and the
continuum.
second
So
question,
with
of
varying
course,
degrees of
is
angle
what do
anomalies.
you think?
You
What
see,
is your
with angle surgery, the older the person, the older the patient, actually the less successful the outcome. In general, I would hesitate to do angle surgery in GOAG more than 12 years of age because I find that in this group, actually the trabeculectomy surgery actually do very well. I mean, they actually have very good outcomes with trabeculectomy surgery. Unless, I mean, I will try angle surgery only if, let's say, they have some highly increased risk of blood-related complications in these children. I may give it a go, but in general, I think in older children, more than 10 to 12 years of age, trabeculectomy surgery actually does much better compared to angle surgery. I don't know whether the rest of the panel
would that
agrees
be
with
Ping,
this.
what do you think?
no? The second question was, would that mechanism also work
The
in
problem about doing angle surgery in older patients, if you look at the results from here,
steroid-induced
is
glaucoma?
that there is a law of diminishing returns as you start going into the 6 and 12s and beyond. So you have to balance that against also, interestingly, the risk of complications, particularly hypotony, actually, which is a bit odd. But if you do angle surgery in older children, you can get more hypotony than you would ever get in the very young children. So it's a bit of a trade-off, really. I'd only do angle surgery in older patients if there was a reason, as you've heard from everybody else here, that if there's a contraindication to external filtration surgery, such as a terrible eye rubber or something, and then I would give ankle surgery a go. But generally speaking, your return is much less as they get older.
Interesting results in cells. For which patients would you
The next
recommend
question is back to you, Ping.
that they have, for example,
It's
glaucoma?
on medical therapy, so a little bit off our topic, but I guess medical therapy is important because it helps delay surgery. So, what is there a first choice? And of course, we all know we have to avoid alpha-GAN, but like, do you have an alternative to alpha-GAN in your medical treatment?
Okay, I'll start with the second question first. So when we wrote the guidelines for the British Pulmonary for Children, um, I wrote that actually you wouldn't use alpha-GAN hormonity in children under 6, and certainly that seems to be the experience here. If you look at the ones who fall asleep, it's very useful if you're on a plane journey. and, but basically, the alternative to bromonidine is iodine, and we've used iodine in very young children, and it doesn't have nearly the same side effects, and of course has a pressure-lowering agent. Of course, there's the issue of tachyphylaxis, but actually, surprisingly, in some children, it does last a lot longer. So it's a very useful adjunct if you want an alpha. agonist, and it's useful. As for your first question about the first agent of choice, I think I suppose it depends. I mean, obviously, most of these children will undergo, if they come early with PCG, they'll have some form of surgery. But what agent I use will depend on what I'm trying to achieve, really. If the pressure is very high, of course, you'll try a variety of agents, including probably most of them, if it's not contraindicated. But interestingly, I also sometimes use pilocarpine, which most people probably haven't gone near for the last 10 years. But if they respond to pilocarpine, they actually get a very good response to ankle surgery. It's a very good predictor of response to ankle surgery. But otherwise, in terms of side effects, of course, latanoprost is the safest. And certainly the trial that we did with Pfizer showed that. But the problem is it doesn't work as well in children as it works in adults. So basically a range depending on what we want out of the treatment. Yeah.
Thank you. The next question is to Anil. We've got a couple of questions for you. One of the questions is, do you use mitomycin C in your combined trap surgery? And if you do, at which stage of the surgery, at what concentration, and at what duration? And the second question is, do you have any tips of identifying the Schlemm's canal in ophthalmic eyes, knowing that they tend to have distorted limbus anatomy?
Yes, thank you. Very nice question. The first question is, do we use antifibrotic agent in primary surgery? I do not use. In first surgery, I avoid using antifibrotic therapy, particularly in young children, because of long-term effects, ill effects of mitomycin. It can lead to chronic hypertony, bleb-related infection, endophthalmitis, etc. That's the reason. But yes, I do use when repeat surgery in refractory glaucoma. In that case, I use mitomycin C in the strength of 0.2 to 0.4 milligrams per ml of mitomycin solution, soaked sponge, multiple sponge, and wide area of application. And the duration of application varies from half a minute to 2 minutes, depending on the situation, depending on the refractory nature of the glaucoma. The second question asked was tips for identifying the Schlemm's canal. The most important thing when you are identifying the anatomical landmarks under a partial thickness scleral flap, you'll have to identify when you go from the corneal side to posterior aspect towards the sclera, a transition zone will appear between the bluish-gray zone, which is outer landmark of the trabecular meshwork, and then it meets the zone, white zone, the sclera. The junction between the two is the area where the location of the scleral spur and is the most important landmark for identifying the Schlemm's canal. Classically, it is said where white meets the blue, Schlemm's wait for you. So that's the dictum. In advanced stage where limbal stretching is very significant, it is necessary to identify and give a gradually deepening incision in the sclerolimbal junction. That's the zone, and a stage will come that outer wall of the Schlemm's canal will be incised, and slow ooze of aqueous is the end point. Too much pressure with the tip of the knife will pierce through the inner wall, that is, it will pierce the trabecular meshwork, it will incise the inner wall of the Schlemm's canal, and a jet of aqueous will come out. That's the wrong step, and we do not want that. We want slow ooze of aqueous as superficial wall of the Schlemm's canal is, inside. That's the identification mark.
Thank you.
Thank you.
The next question is on TCP. So, Alana, you take the question. So does TCP have a role as an adjunct in good prognostic eyes? And what are your thoughts on the micropulse TCP as a modality of treatment for children?
Well, I tend to use cyclodestruction, any type, as a last resort. So the question on using it in good potential eyes, it doesn't really come up that much in children because angle surgery first, and then sometimes repeat angle surgery, as Anap talked about in her talk, very lovely actually, and then possibly trabeculectomy and shunts. But use of cyclodestruction, any type, for me is not a first line procedure. Micropulse, Sean Lin published some data on this in children maybe 2 years ago, which was pretty convincing. And I loved it that he published negative results. It really didn't do that well. It helped in temporarily lowering pressure. Maybe it was early in the course of it, but it really did not lower pressure for a long period of time.
Do you use a pediatric size tube in children as opposed to an adult tube?
No. Really, these are big eyes and they have high pressure, and sometimes the tube is their only way for outflow. And so you want something actually with a large surface area, and I will go for a 350 millimeter shunt, the more surface area. In fact, I rarely use valve shunts because the surface area in those tend to be too small. Patients wind up on medicine or requiring a second tube or further surgery of some type.
There was a mention about leaving the tubes long in the AC. Do you routinely do that?
Yeah, I have to say I do adjust for the child growing, and even if you put it in the tube where you think it's quite deep, because the eye does continue to grow, the tube will get shorter, but it also moves more anteriorly, closer to the cornea sometimes. I showed a brief video on how to shorten the tubes if at some point, you've left it long and you think, okay, the eye has reached its maximum size and I can go ahead and trim this now. And it's quite a easy procedure to do. But yes, I do leave it a little long in a small child, in the initial placement.
Okay, thank you. I think we've come to the end of the question and answer section. And I thank everyone for participating and all the attendees for their attendance. And have a good day ahead. Goodbye.
Goodbye.
Thank you.
Bye-bye.
Well, thank you very
Thank
much
you.
indeed. I think we've gone over time.